Quick question for you. Do you understand what's causing your blood pressure to be elevated? Like why you have a diagnosis of high blood pressure or hypertension as we call it? Well, if you're like 90% of those out there who live with this diagnosis, the answer is no, we don't know. It's actually what we call essential hypertension. Now, I've done a series of videos that talk about blood pressure, and I'll just share them here with you now because they're all foundational to what we're going to be covering in this video. The first is, what is blood pressure? Kind of breaks it down into the different components of systolic and diastolic. The second one is osmoreceptors. So those are one of those mechanisms that we have inside our body that are helping to regulate our blood pressure, along with our baroreceptors. And then we also have the Renin, angiotensin, aldosterone system, again, one of my favorites. So these are three mechanisms that I talk about to help people understand what's going on inside of our body to regulate blood pressure. Now, hypertension is a diagnosis that is given when your blood pressure is elevated over a period of time. That's all important because today we're going to start to look at the treatment methods for high blood pressure. And we've talked about the stepped management in the hypertension video. And today we're going to look at what would happen if you were into step 2. So step 1 was all about diet and lifestyle changes. And in step 2, we start to introduce pharmacological or medicine to help manage blood pressure. Now, because there's so many different sites in the body that are regulating blood pressure, we have to have medications that will drive changes at all of those different sites. And so your treatment plan may look completely different than your neighbor's treatment plan, even though you both have the same diagnosis. Now, because we don't know what's driving that high blood pressure, again, essential hypertension means we don't know what the driving force is. That means we're going to use a variety of medications to help manage it. And so there are 5 main categories of medications that you may have heard you might be currently using to help manage high blood pressure. You may be on one of these, you may be on a combination of these, you might be changing one out for another, and that's okay, that's part of your treatment plan. So the 5 categories are, we have ACE inhibitors, we then have our angiotensin receptor blockers, we have our calcium channel blockers, our beta blockers, and our diuretics. Now there are other categories, but those are the 5 main ones, and we're going to start looking at ACE inhibitors in this video right after this. Welcome back. My name is Tammy and this is NurseMinder, and on this channel we do everything nursing. So if you're new here, consider subscribing below so that you get the next video when it's released. So as we begin to look at ACE inhibitors, we're going to look at first onset of action. Where do they work in the body? Next, we're going to look at how to identify what is an ACE inhibitor by the name. Then we'll look at how people take the medication, some of the side effects to look for in patient teaching. Be sure to stay till the end because there will be an NCLEX review question to help you put those pieces together. We're going to be talking about ACE inhibitors and how they help us to decrease blood pressure and keep our values in a safe range. To start though, we want to just quickly review the renin angiotensin aldosterone pathway, as this is important to understanding the site of action for this medication. Now you can get a full review in the renin angiotensin aldosterone video, and I'll pop that link up here for you. But just as an overview, when the kidney sense that there's decreased volume, they like to be fed. They like to have a lot of fluid coming to them. So when that drops, the kidneys will send up a flag, yo, SOS, we need some help over here. Now, what's currently always available in our bloodstream is called angiotensinogen. This is readily available, it's inactive, it's not doing anything but waiting to be called into action. So when that flag goes up, the liver is going to produce an enzyme that will convert angiotensinogen into its first conversion, because there's a couple steps, and it's going to convert it into angiotensin 1. Still inactive, and angiotensin 1 cannot elicit a change on your blood pressure. But it is a necessary step to creating a change in blood pressure. When angiotensin 1 reaches the lungs, there's another enzyme reaction that happens here that converts it into angiotensin 2. So we have one liver, we have 2 lungs, and that's one way to help remember those 2. Angiotensin 2 then is the actual thing that causes a change in your blood pressure. When angiotensin 2 is activated, our vessels will constrict and get narrow to increase the blood pressure. And it will also have an effect on the kidney in that it will help to retain salt and water. All good things if you have low blood pressure. But now we have high blood pressure and we need to stop this process. This is one of the ways that we can help lower blood pressure. ACE inhibitors work here between angiotensin 1 and angiotensin 2. They're going to stop that conversion. So that means the vessels will stay dilated and they will not constrict. So the result of taking an ACE inhibitor means we will have larger vessels, so our blood pressure drops, and we're going to excrete or pee out more water to decrease the amount of blood, the volume inside the vessel. Now, one of the first things we should know is how to identify what medication is an ACE inhibitor. And what I love about generic names of drugs is that they give us clues a lot of the time. So if you have a drug that ends in the word pril, P-R-I-L, Ramipril, captopril, lisinopril, that ending tells me it's an ACE inhibitor and it's going to help prevent. So here's a little bit of a helpful memory. I'll use a little I there. PR stands for prevent angiotensin 1 from becoming angiotensin 2. So there's where it's going to work. Its site of action is in that conversion. Now, in terms of how much you take and how often you take, that would be a decision made with your healthcare team based on your particular circumstances. I will share, though, that these are oral medications. They're either in a tablet or a capsule. Now, enalapril does have a parenteral route as well. It's called enalapril at. There's an AT at the end of that word. But generally, it's going to be an oral medication. And you may find you're taking it once a day, which we call OD in medical terms. Twice a day is BID, and 3 times a day is TID. So again, your individual dosing will be different than those of your neighbors and your friends because your situation is unique. Now, in terms of when to take it in regards to food, that's going to vary as well. So for example, captopril, you'd want to take that an hour before food because the food will actually decrease how much the body can absorb. So we want to make sure we're taking it without food. Ramipril, on the other hand, doesn't have those same restrictions and you can take that with or without food. So again, you want to be making sure you're looking at the specific drug you're taking to know how to best administer it to get the full effect. Now, of course, you will be taking this medication along with your lifestyle changes. So that might be a reduced salt diet, that might be increase your activity level. It may include decreasing alcohol consumption. Again, personally tailored to you. But to recognize this is a stepped approach, right? So we always start with lifestyle changes and we add, we never get rid of in order to maximize our impact. Now let's talk about side effects. We can probably predict some of what's going to happen based on knowing how it acts here at preventing this conversion. So we know when angiotensin 2 is working, it makes our vessels really small and that's going to shoot up our blood pressure. But when we stop it, this is going to lower blood pressure. So now our side effects are always related to therapeutic dosing and then what happens if there's too much, like the body does not, or the body over responds to it. So if I have a decreased blood pressure, I might have symptoms of feeling dizzy, faint, confused, weak, tired. And when that happens, there's another compensatory mechanism in our body, and that's the heart. That means the heart's going to start to kick into overdrive and it's going to pump harder. So another side effect would be a high heart rate. We call that a reflexive tachycardia. The heart responds because of the lower amount of blood coming to it, and it likes to also be fed, so it's going to kick it up because it's responsible for feeding the rest of the body. With that heart having to work harder, that means the muscles might get larger and we can end up having a cardiac hypertrophy, which means the muscles are bigger. We can have chest pain because the heart's working pretty hard. We can have arrhythmias because when the heart is stressed, then there can be changes in the way that it works. So a lot of cardiac side effects related to ACE inhibitors. Now, of course, when we have a low blood pressure, we can also feel nauseous. So there's another side effect with an ACE inhibitor is nausea. Of course, that's also related to just putting anything in the stomach. Anytime you take a medication, it's possible you're going to feel nauseous. But it's also related to the risk of a decreasing blood pressure. Two potential reasons why your patient may feel nausea. Now, if we go back, angiotensin 2 also impacts aldosterone release from the adrenal cortex. And when we stop aldosterone from being released, we actually increase the amount of potassium that is reabsorbed into the body. So we end up having a risk for hyperkalemia, or increased potassium in our bloodstream, which is another factor for arrhythmias in the heart. Now, there are two side effects that we want to make sure we're educating our patients on. And one is they may have this unrelenting cough, this dry cough. It's common with ACE inhibitors. The second is a diagnosis called pancytopenia. And that is where we have low red blood cells, low white blood cells, and low platelets. Important, because if we have low platelets, they're not going to be able to prevent bleeding as easily as those not on ACE inhibitors. So if they start to bruise easily, they should come back in. If they're really short of breath, that might be a result of the decreased red blood cells, which means decreased hemoglobin, which means decreased oxygenation. Really important side effects to be talking to your patients about to make sure they know when to come back. One last consideration is the patient's current health status. Now, in terms of the medication, how it gets through our body and out of our body, it is metabolized largely by the liver. So if you have a patient that has liver disease or liver pathology, we may need to adjust the dosing because it's not being metabolized in the way that our research shows it should be or could be based on a healthy individual. The second thing is it's excreted by the kidneys. And if you have anybody who's got kidney disease, they may not be getting rid of that medication in their body, which means there will be a buildup. And if there's a buildup of the medication that can be utilized at the cellular level, we can have profound hypotension as a result. We can have profound hyperkalemia as a result, cardiac issues. So we want to be monitoring our lab work in our patients who have those coexisting morbidities in terms of kidney and liver disease to make sure that we have we're not adding any risk factors to them. Wow, we have covered a lot of information. We started out with looking at how ACE inhibitors work in the body. Fascinating stuff to me. We then went into a whole host of information about how to name them and identify them, how to take them, what side effects and patient teaching we need to be considering, and our patients' personal conditions in terms of how healthy their body is to let this medication work to its full capacity. Now it's time for our NCLEX review. So here's a typical question. The nurse is talking to a patient about their new prescription for captopril. Which statement made by the patient demonstrates that the teaching has been effective? I can assess the effectiveness of this dose by watching for signs of hypertension. Should I notice bruises or a change in my energy level, I'll call the doctor. Taking this medication at nighttime is just going to cause me to stay up and pee all night. I will increase my dietary intake of sodium. Take a moment now and select your answer. Hey guys, if you selected that they should come back when they get bruises, you'd be correct, and that's related to their pancytopenia. Now, the reason A is incorrect is because we would want to look for signs of hypotension, not hypertension. And we know hypertension is the silent killer, so there's not likely to be any signs and symptoms. But hypotension is a side effect of the medication. Now, C is not correct because it's not going to make them stay up all night and pee. It's not a diuretic. It's just going to prevent the reabsorption of water. And D is not correct because we don't want to increase dietary sodium. That's going to increase blood pressure. We actually want to decrease dietary sodium. So well done. So now it's your turn to let me know how this is working for you. Give it a thumbs up if you like this video. Make sure you subscribe and hit the button so you get the notification for the next video. And in the comment section below, absolutely put your thoughts in there. Let me know what you're thinking. Do you have any analogies that you use? Do you have any other information you'd like to add? Now, if you're not quite ready to go back to work or you want to binge a little bit more, I've got a ton of videos popping up here that will keep you entertained for hours. Take care, guys, and make it a great day.